Hello, everyone. My name is Yvette McQuat, and I work with the International Institute for Qualitative Methodology. I'd like to thank you all today for coming to our second webinar for the Mixed Methods webinar series. Excuse me. Today we'll be listening to Dr. Leslie Curry on the topic of mixed methods in health sciences, applications, and challenges. I'll just give a quick run through of how the session's going to work. Going to do a quick introduction. All of you are muted right now and will be muted for the entire session. After Dr. Curry has spoken, if you have any questions, you can raise your hand and I'll give you the microphone. If you don't have a microphone, you can enter in your questions at the chat and then we can read those out. So we'll go ahead and get started. Dr. Leslie Curry is Senior Research Scientist at the Yale School of Public Health, lecturer in Yale College, and core faculty at the Yale Global Health Leadership Institute. Leslie's research focuses on healthcare access, quality and outcomes in hospital, community and institutional settings in the U.S. and internationally. She is especially interested in the development and scale-up of innovative evidence-based health practices, programs, and policies, and regularly collaborates with government agencies and healthcare providers in these efforts. Leslie is a recognized expert in qualitative and mixed methods. She was a member of an advisory committee appointed by the Office of Behavioral and Social Sciences Research at the National Institutes of Health, charged with defining best practices in mixed methods research. Leslie, the floor is yours. You can go ahead.
My good.
Leslie?
Hello?
Okay, hi, I can hear you now.
Can you? Okay, great. So we're okay? We're live here?
Yep, we're live and I can hear you.
Okay, great. Thanks. Thank you, everybody, for joining today. I also want to thank Rebecca Pepe, Heather Fosberg, and Sarah Merchant, who helped me put this talk together. I plan to speak for maybe 45 minutes with providing an overview of mixed methods in the health sciences, talking a little bit about some key challenges from our team's experience, and then moving into an illustration of one of the current studies we're doing that uses mixed methods. So we'll kind of jump in here. And really just as a starting point, I want to kind of share with you the way we think about health sciences in terms of operational definition. We consider the health sciences to include clinical research, things like healthcare decision-making, various kinds of intervention trials. We also think of health sciences as including health services research. Here we explore things like measurement development, organizational performance, which is what we'll talk about today, quality of care, access, utilization, and various dimensions of patient care experiences. And then finally, we consider the health sciences to also embrace the discipline of implementation science, which, sort of the what, how, and why of implementation in the context of healthcare. So mixed methods are useful for many things. They can help us understand various phenomena through multiple lenses. The methods can help us provide context for given phenomenon. They can help us examine processes and experiences and outcomes in complex settings. And they can also be used to inform subsequent research development. So I want to take just a moment on this illustrative table, which can be found in a paper that our team wrote in Circulation Quality Care Outcomes. So I won't work through the whole table, but maybe just focus on one example. We'll look at the second bar. So for instance, if we were interested in the central topic of organizational performance, so the performance of hospitals in care of patients with acute myocardial infarction, that's the example we'll work through today. On the qualitative side, we might use qualitative methods to really dig deeply to understand the complex processes around care delivery and the broader organizational environment in which care is delivered. A quantitative component of a mixed methods design might focus on identifying factors that are statistically associated with a defined outcome, for instance, 30-day risk standardized mortality rates for patients with AMI. I want to just take a second to mention that I had sent some articles to Yvette. She'll post them on the website because in order to, I'm really mindful of time. So in order to move through a review of, lots of content, I'll be pointing to articles that our team has written just so that you can dig deeper on any particular issue if you're interested. So let's take just a couple of minutes maybe to highlight some challenges that aren't necessarily unique to mixed methods research, but perhaps may be more common in this area, at least from our team's experience. These are some of the things that we struggle with. First is securing adequate resources. So not just financial resources, but often mixed method studies are large in scope, they're multifaceted, they often require more time depending on the phased design, and they also often require various types of expertise that we don't typically assemble on our teams. Our group has a paper under review looking at funding trends. It updates a prior analysis by Vicki Plano-Clark. Vicki has a paper in the Journal of Mixed Methods Research on funding trends, but there is, I think, an encouraging sort of increase, at least in the U.S. context. We analyzed NIH-funded programs within the U.S. to see that there are increasing investments in mixed methods research, though still a very small portion of the overall investment in research. The second challenge that we often work through is writing competitive grant applications. Because this is sort of emerging, at least in the health sciences, as a formal set of methodologies, it can be difficult to write applications that are compelling for reviewers who may be somewhat novice. And so I had the good fortune of working with a group led by John Creswell and Ann Klassen and others for the Office of Behavioral and Social Sciences Research at NIH. And that large team put together a review and guidance document that I also encourage people to look at about how to construct a grant application using mixed methods for funding. And that can be a useful tool. And then lastly, I want to spend maybe just a couple of minutes on this issue of building and managing mixed methods teams, which I think it really is a unique challenge in terms of the group dynamics and management of people with highly divergent kinds of expertise. So our group wrote a paper that's in Journal of Mixed Methods Research, myself, Vicki Plano-Clark, Mike Fetters, Alicia Hokahan, and others, to talk about the experience of working in mixed methods teams. So what we see here is a representation of a schematic that represents an individual team member on a mixed methods team. This draws heavily from work done by David Berg here at Yale, an organizational psychologist, who talks about the role of representational groups in teams. And so if in the lower hand circle we see the mixed methods team as the focal group, so this is the team that we assemble to implement a particular research project, any given team member, so here team member 1, has a number of home groups that they bring to the work of the team. And these home groups really are critical for the essential diversity that brings the richness to mixed methods work. And so an individual team member has particular disciplinary training, particular methods expertise, may bring to the group a certain level of authority or status, has their own particular organizational affiliation. All of these home groups are critical to be represented within the mixed methods team. At the same time, there are dynamics that happen all throughout the team. The dynamics happen from, this is a team now that has 5 representatives, and within it we can see each individual is working back and forth from their own home groups. So the qualitative researcher is working back and forth across the boundary, reaching out towards his qualitative research expertise and bringing it back into the team. Another team member may be reaching back out to their clinical expertise and bringing that back into the team. And then there are interactions between the team members. And so managing these dynamics takes really very careful attention and leadership. And I think it's an encouraging area of growth for us all to be thinking about how to manage teams successfully in this environment. So that's it for an overview. I'm going to stop there for our 10-minute allocation on the overview and move to an example of a problem that our team hoped to tackle using mixed methods research. The problem is acute myocardial infarction, which is a common and life-threatening illness. In the U.S., each year over 700,000 people will have a heart attack, and about 125,000 of them will die. There's a huge evidence base, lots of clinical literature looking at tools and technology and pharmacology directed at improving survival from AMI. But our team was really interested in looking also deeper at the context in which care is provided. And so this is organizational culture. And in this instance, looking at the culture of hospitals that care for patients with AMI. Just a minute or two to come to kind of a shared definition of organizational culture. And our team appreciates the definition offered by Edgar Schein, which is that organizational culture is a pattern of basic assumptions invented or developed by a given group as it learns to cope with its problems of external adaptation and internal integration. And so in our example here of care of patients with AMI, hospitals are facing external adaptation to forces like reimbursement rates, regulation, and also within the boundaries of the hospital, they're taking in new knowledge and learning how to integrate and work effectively in care delivery. So a more simple way of thinking about organizational culture is really it's the way we do things around here. Edgar Schein describes organizational culture as having 3 layers, sort of an iceberg. And the first layer, the things that we see, the things that are visible, he describes as artifacts. And so in our example here of care for patients with AMI, in a hospital you might see a departmental award for reporting near misses or near errors on the unit. We may also see a graphic sort of pillars of excellence, a logo that might be a visual reminder of the missions or goals of a hospital. Values are semi-visible. They lay kind of just beneath the artifacts that are manifest in a particular environment. And values really are the beliefs about how to be successful in a given environment. An example of a value in this context might be the notion of psychological safety that Amy Edmondson has written about, meaning that the environment is a safe place in which employees can voice their concerns, express different points of view without fear of sort of reprisal or retribution. And then the most fundamental sort of underlying invisible beliefs are about what motivates people at their root. And in this example, we might think really the motivation, the deep root motivation for awards for near misses, for having open, safe space for communication is really that the hospital's priority is patient safety as a #1 kind of driving force. So that's a kind of an overview of how we think about organizational culture. And I want to walk you through the evidence base that brought us to this place where we decided to study organizational culture. So we used a positive deviance approach. This is described in a paper by Bradley, Curry, Krumholtz, and others in Implementation Science, and I sent that across to Yvette to post, where we describe a process that where we modified other work on positive deviance to focus on improving quality of healthcare. And in this approach, there are 5 steps, and I'll walk us through these 5 steps for this example. The first is to identify the positive deviance, those who are doing very well on a particular outcome of interest. The second phase is to qualitatively study them, looking deeply in the organizations in order to generate hypotheses. The third step is to test those hypotheses quantitatively in a large representative sample of hospitals in this case. And the fourth and fifth steps, of course, are disseminating with partner input and evaluating the uptake and impact of the strategies that are discovered. In the study that I'll be describing, we identified the top and bottom 5% of hospitals in RSMR performance. So those hospitals that were doing really very, very well in terms of mortality rates for patients with AMI, and those that were doing not so well. We carried out in-depth interviews with key staff in care of patients, and then we moved to a cross-sectional survey, the 91% response rate in this instance, in order to test the hypotheses that we had developed. And so next I'll take just a minute to share with you what we found in this series of projects.
Leslie, I think you're cutting.
And first is the qualitative component. So the first qualitative finding was really a focus on organizational values and goals. So common visions, really the glue that holds everything together. For instance, to be really provide the absolute best care for patients with AMI possible. A second theme from the qualitative data was the notion of strong communication and coordination across groups for seamless transitions in care of patients with AMI. So staff talked about recognizing the interdependencies in the group. You know, everyone from the housekeeper to the surgeon plays a role, this idea. A third theme was problem solving and learning. So for instance, in this condition of psychological safety where we're looking at adverse events, embracing them really as opportunities to learn. And then last, the notion, or second to last, the notion of senior management involvement. So here we learned about financial and non-financial resources directed to the priority of care of patients with AMI. We saw senior managers both fostering accountability and supporting high performance within staff, using data to drive decisions. And then the last qualitative theme was a broad staff presence and expertise in AMI care. So here we learned from the top performing hospitals that they were involving pharmacy, engaging pharmacy actively in care of patients. Nurses were empowered to be a full part of the care team, quality improvement represented in all of the initiatives to improve care in the organization. So just because this is a mixed methods kind of webinar, I want to just take a second to show you a little bit about how we operationalized from the qualitative to the quantitative survey, just give you a couple of examples. So in this domain of broad staff presence and expertise, here's a quote from the qualitative data. I started writing my consult notes. Over the years, it's just become the standard. That was my way of breaking into the culture, saying, this is my note, I want you to read it. It's not in the nurses section. I have some ideas, and I'm open to talking about it. This, together with other qualitative data, resulted in one item, actually several items that related to staff presence, but here's one example. Item number 65, nurses are comfortable checking with physicians if they have concerns about patient care. Second example in this domain of communication and coordination among groups. Everyone in this hospital, from the housekeeper to the CEO, plays a role. The housekeeping needs to know why it's important for them to go out and do their job. No one has an insignificant role in it, so everybody needs to be educated, everyone. This item was operationalized as clinicians involved in the care of patients with AMI value each other's skills and talents. And then one last example in the domain of problem solving and learning. Here a quote from a director of quality management. The performance improvement team identifies action steps. The plan is put in place, and then we continue to measure to see if it's working or not working. You identify, you improve, you monitor, you tweak, and that's the model they've been using for 10 years. This item, clinicians are encouraged to creatively solve problems related to AMI care processes. So what did we find? In the broad survey of U.S. hospitals, 537 hospitals, we found strategies, thank you, to reduce 30-day mortality rates that were in these 5 domains. The first was pharmacist engagement, so pharmacy playing a key role in the care planning assessment for patients with AMI, was associated with a 0.41 reduction in RSMR. Having physician and nurse champions as a dyad, a functional pair, was associated with a 0.88% decrease in standardized mortality rates. Collaboration with EMS, or emergency medical services. In the United States, this is the pre-hospital emergency system that cares for and transports patients into hospital. was associated with a 0.70 reduction in RSMR. Having nurses assigned to the catheterization lab, this is a dedicated nurses so that they're not cross-trained moving across units in the hospital, was associated with a 0.44% reduction. And lastly, creative problem solving. We saw a little bit about the origins of this item, was associated with a 0.84% decrease in risk standardized mortality rate. So these, 0.5 to 1% decreases in absolute differences in RSMRs are considered really clinically significant. When there was a drug invented in the 1980s, streptokinase, a 1% increase in RSMR was considered a blockbuster drug. So lots of promise here to improve survival rates for patients with AMI. And yet, we really discovered several things, an opportunity that needed to be leveraged. First, most hospitals were reporting using only one of these 5 strategies. Very few were using all 5 strategies in their work. And we found that for those that did use all 5 strategies, their 30-day RSMRs were 2% lower. And so these strategies, really we see them as signals or proxies for underlying aspects of organizational culture. And they present negligible risk. They also, most of them require few new resources, and we hypothesize that they're likely to have spillover effects more broadly. And so given this, well, I guess I'll stop for one moment. I meant to mention that we've got 2 papers that describe this study and these findings, both in the Annals of Internal Medicine, one by Curry et al. And one by Bradley et al. That can give you sort of more detail on that study. But of course, we didn't want to stop there with the papers. We actually wanted to make a difference in the world. And so we set about yet another project that I want to describe, which is the mixed methods study that we'll use as our sort of more of mixed methods. And this project is called Leadership Saves Lives. I'll be describing briefly the methods, and then I'll refer you to a paper in Implementation Science by Curry et al., which describes the protocol in greater depth. I also want to note that this is a project that is really led by a terrific team here at the Global Health Leadership Institute that includes Betsy Bradley, Erica Lenanders, Ahira McNatt, Heather Fosberg, and a whole host of folks here at GHLI, as well as our partners nationally. And so I want to kind of certainly acknowledge that. So the study aims for Leadership Saves Lives are 3. The first is to implement a 2-year deep intervention in 10 U.S. hospitals using mixed methods in order to change organizational culture so that it improves performance and care of patients with AMI. It's an ambitious, ambitious project. We set about, we're looking to evaluate 3 outcomes. The first is the use of the evidence-based strategies that we just reviewed, those 5 strategies. The second are positive improvements or changes in organizational culture, those dimensions of culture that we also just reviewed. And the third outcome is in-hospital mortality rates for patients with AMI. In the U.S., reporting of risk standardized mortality rates is an 18-month lag, and so we're not able to look real time at the RSMRs. But we expect that they're not that different than the in-hospital mortality rates, but that's where we are with the third clinical outcome for the project. And the third aim is to really describe, using deep qualitative methods, the process of change. So how change happened in these 10 intervention hospitals over the period of 2 years. So to walk us through the sample development, the first step was for us to identify a receptive hospital network. Because this is a deep intervention requiring commitment on the part of the hospital and a hospital sort of openness to the notion of organizational culture and its role in performance, we partnered with a network where we had a relationship with leadership in the network from prior work. This is the Mayo Clinic Care Network, which at the time had 21 hospitals in the network. It's grown rapidly since this time. I think it has over 30 now. We applied eligibility criteria, so we excluded hospitals that had volume of less than 200 because we wanted to sort of have the greatest impact, or had above average performance, so they were already doing well in care of patients with AMI. So we were left with 18. And then we selected our sample. We randomized the list of 18, and we worked systematically down through the list, selecting hospitals that were diverse in geographic region and in teaching status. So this is just a little schematic of what the sample looks like. The blue dots are the MCCN, are the intervention hospitals, and the green dots are the MCCN hospitals. I'm looking because I think the legend is inverted on this graphic. So there are 10 U.S. hospitals across all of these states that are participating. And then in approaching these hospitals, the recruitment, I will say, was much more in-depth than we normally do with our survey research or even our hospital-based research, because we really were attempting to assess the hospital's receptivity to this notion of collaborating in this deep intervention for organizational culture change. And so this process of determining receptivity involved exploratory interviews with both the chief executive officer, the C-suite, the executives in the hospital, as well as the leadership team, to determine whether or not they felt they could actively engage in the hospital, in the intervention. Two, I think, said no. One was already, they felt, working well in organizational culture, and the other was going through a large reorganization, and so the timing wasn't right. And so we brought the remaining 10 hospitals on board. And then we lastly asked them to nominate hospitals in their peer networks. We have a theory that we're trying to test out also in this project, which is related to the aided model of diffusion. I didn't send that paper to Yvette, but I will, maybe make a note. This is a model where we have studied diffusion of innovation across networks and believe that the role of peers in spreading innovations across networks is really quite critical. And so we were interested in looking not only at the intervention hospitals, but what happened in terms of spread of information outside the intervention to those in their networks. And so that looks something like this, where these are the, this represents the 10 intervention hospitals in the LSL study. They're then surrounded by the remaining hospitals that are in the Mayo Clinic Care Network. And so they have relationships with various hospitals in the MCCN network. And they're also, operating in their own geographic regions and across academic institutions where they're reaching out to their own individual peer networks. And so we're studying these relationships and information flow as well. So what's the intervention look like? As this schematic shows, the intervention is 24 months long. So we're out in these hospitals for 2 years. The first component, and it's ongoing, is a remote support component where we're available to the hospitals and they're available to each other through an online learning platform, through various small community calls that we convene, and through intermediate consultations with staff here and faculty here at the Global Health Leadership Institute. The second element of the intervention are 3 annual convenings where we bring together 4 representatives from each of the intervention hospitals, those who are sort of in the key leadership roles on their guiding coalitions. And these hospital-based convenings focus on sharing new learnings across the hospitals and providing opportunities for very close peer collaboration on strategies and dimensions of culture change. And then every 6 months, a team of facilitators from the Global Health Leadership Institute, sometimes accompanied by clinicians such as interventional cardiologists or executives, head out to the field, and they spend 1 to 2 days in each hospital running workshops that have core content that's similar, but that are tailored to the needs, interests of each particular hospital. So the intervention has those 3 components. And then the research piece runs along underneath this. We are, as I mentioned, using a concurrent mixed methods design. So the first piece is a survey of both the intervention hospitals and their peer networks. In the intervention hospitals, we're interviewing all those who are part of the guiding coalition, which is the team assembled on site in the hospital to work on Leadership Saves Lives in the hospital. And there are typically 10 to 15 members of the guiding coalition, so they each complete a survey. And then out at the peer networks, there's a single respondent for those hospitals. Oops, sorry. People took their Dramamine pills. Hold on. The second piece of the research is our qualitative interviews. These are happening at 3 time points through, across the study, where we're out in the hospitals conducting interviews with key informants that include the guiding coalition members and others, executives and others in the hospital. And we're also, I'm so sorry, we're also conducting observations at these time points. And so that gives you a sense of the research and intervention components. So maybe I'll tell you a little bit about where we are. You know, we are now 18 months into the intervention. So we're about halfway through the second year. We've completed workshops, the convenings, the remote support, and are working along in multiple ways. We've had 20 different site visits at the intervention hospitals. We've completed 350 surveys. And for those of you who are familiar with qualitative work, we're finding ourselves deep in thousands of pages of narrative data to be analyzed. Maybe I'll linger here for just a moment because this is the largest mixed methods project that our team has undertaken for a couple of reasons. One is the longitudinal nature, so we're out following hospitals for over this 2-year period, and so we're having the opportunity to really watch change unfold in real time and to understand deeply how things are happening in the hospitals. The longitudinal qualitative piece is new for us. And then the sheer volume, frankly, of the qualitative data is something that's also new for our team. Really tremendously exciting, but also, you know, a little bit daunting. So I'll tell you a little bit about what we've been seeing so far. Again, sort of very, very early findings. We're still in the midst of data collection. But here at the 12-month point, looking at the 12-month intervention data, we've seen some encouraging uptake of these 5 strategies. So the first being pharmacist engagement. We've seen large uptake of this strategy. One of the things that we're learning in this process as well, and it was expected, is that each hospital will sort of adapt this strategy to fit its particular context. And so something like pharmacist engagement may look like a pharmacist rounding on all patients with AMI in a hospital, or it may look like something different, excuse me, something different where a pharmacist is weighing in into the chart at various times throughout the patient hospitalization at the point of discharge. And so hospitals are adapting these strategies, but a number of them have embraced and taken up that particular strategy. We've seen initially 5 hospitals reported that they were doing creative problem solving. I think they're learning more about what that looks like through the process of working together and in the workshops and convenings. We've seen one hospital increase or one hospital reporting that strategy. There's been fair uptake of the MD and physician dyad working together closely as champions for care of patients with AMI. We've also seen uptake in reporting of strategies around collaboration with EMS, the emergency medical services. And most hospitals were already doing dedicated staffing of nurses to the cath lab. And so most reported they were already doing that work. We've seen a final hospital adopt that strategy. We've also seen some growth in the number of strategies used. So in this chart, the front bars are the baseline reporting. And so you see most hospitals reporting using just 1 or 2 strategies. And at year 1, the lighter blue bars in the back, we're seeing more uptake where 7 hospitals are reporting using 4 of these strategies. What are we seeing in terms of organizational culture? This is where we, honestly, we expect to really have the most learning. We're managing the 4,000 pages in an Atlas data set. So some of you might recognize the background screen here as a screenshot from Atlas. And this, again, is just the very, very earliest sharing of some emerging themes from the qualitative work. We're learning about open versus closed boundaries, so whether the hospital is working outside, reaching outside its bounds to engage with EMS or with post-hospital providers, also open versus closed boundaries within the hospital. So are the various units, speaking to each other? Is the emergency department collaborating more closely with the catheterization lab and vice versa? We're learning about how organizations respond to stress, at least in the U.S. context, a tremendously stressful time for hospitals. This gets to the external adaptation from SHINE that I mentioned earlier, dealing with increasing pressures around reimbursements, regulations, quality metrics. And so we're watching how those stressors are manifesting within hospitals and how they're responding to them. We're learning about group dynamics and leadership within the context of the guiding coalitions that I mentioned. So these are teams of clinicians who typically have not worked together on single unified projects, and so we're learning lots about how they come together and function as a team. We're learning about how clinicians and administrators engage in large-scale efforts like organizational culture change. What does engagement look like from the senior leadership level? We're also seeing some interesting discussions of authenticity of commitment to change. So is it really, is this intervention to improve organizational culture another kind of flavor of the month? Are we looking really at, quality improvement fatigue? Or are people really fully engaged and committed to this particular initiative? So those are just some very high-level ideas of what we're seeing in the themes. And lastly, I guess I want to mention really that we know the integration of the quantitative and qualitative data is really a hallmark of mixed methods. And so in this project, the plan is to use integration through merging of the data. Mike Fetters has led a nice paper in health services research on what is integration and mixed methods. So I've sent that across to Yvette as well. And so we're, for instance, anticipating that some of the qualitative data will map really very directly onto the quantitative measures and tell us more about the how, about the mechanisms behind. So for instance, if we see, an increase in reported strategies of pharmacist engagement or an increase in senior leadership support of culture change initiatives, we'll be able to see sort of the magnitude of that change, but also the nature or quality of it. So we plan to integrate the data in that way. And we also expect, given the scope of the qualitative data, that we'll be generating some de novo hypotheses. We're interested in watching closely this open versus closed boundaries and some of the other qualitative, some of the other ideas that are emerging from the qualitative analysis. So I see we're just about at 40 minutes, so I think we did well in our timing. And so I think I'll close with this and kind of turn it over to you all for questions. I want to thank everybody for your patience with my zooming through the Prezi, and happy to share more articles if there are things you want to hear more about. I can send things across to Yvette, and I think she said she'll post them on the website. So we have one question that are we going to post the slides? And yes, happy to, and happy to have them shared in any way. Some of the schematics and stuff we pulled from our text. Marcela Nunez and I wrote a text for SAGE publications that is called Mixed Methods in Health Sciences Research. I think that's the title. And so you're free to use those images as well. Let's see, what type of analysis are you folks using for the interview data? Yeah, so we have a large large team of 6 members, plus a couple of content experts that we bring into the process kind of throughout. We, as many of you, I'm sure, use multidisciplinary teams, so people have really very different backgrounds. And we'll be using Atlas to support us in the constant comparative methods. So looking, kind of carefully back and forth during iterative steps throughout the process of analysis to identify recurrent or emerging concepts. To clarify, please, what was the sample selected from the peer network of the first hospital? Let's see. I think I understand. So how did we identify the peer networks? Each of the key contacts at the intervention hospital, so each of the 10 hospitals has a kind of lead contact. That individual was asked to confer with the team and identify 3 to, I think, 5 of the other hospitals with whom they most often share information about caring for patients. And so I think for the most part, these are sort of regionally similar hospitals. Some may have distal hospitals, for instance, if they're academic medicine networks. I hope that answers. If not, please email me. Here's my email on the screen. Happy to share more detail. How do you plan to disseminate? How do you go about deciding how to divide the data for different journals? Well, I would love to have somebody type in the answer to that in the chat box for me. Let's see, the dissemination plan, rather daunting, but I think an opportunity, and an opportunity for all of us, I think, on this call who are interested in mixed methods and pushing them out in a fairly new arena. It's quite challenging, as we all know, to publish full mixed methods manuscripts in single journal articles. So what we've done in the past, the 2 Annals of Internal Medicine articles that I sent across were from our other mixed methods study, where honestly we broke them in half. So the first paper was the qualitative paper, and the second paper was the quantitative paper. We tried to crosswalk those back and forth as much as possible, and pointing back and forth in order to try and get people to have a sense of the overall integration across the data set. But we're thinking they're going to have to be separate papers. And hopefully beyond the papers, multiple ways of dissemination. We're actually in the process of writing another grant to fund a different kind of dissemination beyond the journals, because honestly our team is feeling more and more convinced that we have to do better at knowledge translation, and so publishing the papers is really only the first step in the process. There's lots more that comes after that. So dissemination using electronic platforms and being able to push out lots of the qualitative learnings that we won't be able to fit into the journal article. Hopefully that helps a little bit. Let's see. Hi, Leslie. Would you please describe, please describe the trustworthiness in the qualitative phase? Maybe we take this one offline. I'm not sure I understand fully, but we have done sort of, in terms of the qualitative piece, we're obviously implemented a very careful audit trail, because there are adaptations happening to the intervention across site. We're learning lots about, through various iterations of the qualitative data in this longitudinal design. We know we have to pay very careful attention to changing instrumentation. The survey is not changing over time, but the qualitative data collection is being informed in each wave. And in terms of the various kinds of biases or Hawthorne effects, we're having multiple on-site observation points. We're interviewing multiple staff members at each hospital and using trained interviewers who know how to use scripted probes so that they're pulling respondents to be very detailed in their explanations. I'm happy to take more offline. Are you using theoretical sampling for our qualitative research? Let's see. Yes. The sample is changing. So the number of hospitals is fixed. So we're in 10 intervention hospitals, and that's not changing. But the data collection within each is theoretically driven. So for instance, we're going back out each time in this way, in these 3 waves, to see the same members of the guiding coalition. So we'll have repeated interviews with the core group. And each time we ask whether there's anybody else critical that we should be talking with. So I mentioned, for example, at one hospital, they feel it's critical for us to talk to their CEO each time. And so we have some kind of snowball sampling that happens within each site. And then we are doing analysis in each wave of the large qualitative data. So there are 3 waves of data. We're now, deep in interviewing the second wave, analyzing the second wave. And what we're learning there will help us focus the last wave of data collection. I hope that helps a little, and I'm happy to take more questions offline on that one. Would you repeat the reference for the tool of mixed methods? Yes, the grant application. This is a fantastic resource. I didn't send it to Yvette. I will if Becca writes that down. But it's also available on the NIH website, I'm sure. The Office of Behavioral and Social Science Research, I can only say it by the acronym, OBSSR, and it's called Best Practices in Writing Mixed Methods Grant Applications or something like that. But I'll make sure I send it to Yvette. And I think it is hopefully a helpful resource. People on the committee were really very generous in sharing their own work, and colleagues were really generous in sharing example applications. I might also point you to, and I'm not trying to be self-promoting here, the royalties on this book I think are 23 cents, but in our Mixed Methods in the Health Sciences book for SAGE, there is a chapter on mixed methods grant applications, and I will here also really a big generous thank you to researchers. I think they were all US based, but colleagues who share their experiences in writing grants that ultimately were funded. So that chapter in the book not only shows examples, but has some tips from funded researchers who talked about how they got stuff funded. So those are a couple of resources. Let's see. Sorry, we're just scrolling along. Thank you for your questions, everyone. Let's see. I may have missed this, but I'm wondering whether you focused on organizational culture change solely, or if you're also looking at individual behavior change. Yes, so this is really interesting, and I think we have the opportunity to do both because sort of behaviors change within an organizational context. And so while we're not deliberately focusing on individual behaviors, that's of course what we're learning when we see culture change. So for instance, things like physician leaders who begin to behave differently in meetings where agendas may be set collectively, or if there's a nurse champion, she's empowered to set the agenda and drive the meetings. And so the theory, I think, for us is that individual behavior change will be happening, and an artifact, consequence, implication of those behavior changes is that organizational culture change will follow. I don't know if that answers fully. Maybe, thanks for clarification. Okay. I don't know if there are other questions that people have or things that I should just talk about in our final few minutes. I'm happy to have people also chime in with their experience. As I did share, I think very honestly, this is a large project, the largest that we've attempted on our team. And so we're learning, we're learning as we go in some respects around the scope. Let's see, here's a question. How long did it take from inception to finalize the study? So that's helpful, thank you. I would say well, the study itself is funded for 3 years. We probably did a year's worth of conceptualization and development, finding partners, finding a funder, thinking about complex measurement. So probably a year in development, 3 years of funding. And I will say, and I really would value people's input on this as well, that we expect we're not going to see culture change overnight. We do expect we're going to see movement. We already have on the strategies. We've seen some movement in some dimensions of organizational culture, but our team feels fairly certain that this is a 5 to 10 year sort of project. Of course, none of us get the luxury of that much funding. So we're going to incentivize and support the intervention hospitals to sort of follow their own progress forward. And honestly, I think they're so motivated, that they will. So I would say we expect to really see demonstrable change on the final outcome, which is, in-hospital mortality rates or 30-day mortality rates would not be for, several years. And so it would be really interesting to keep following them. Let's see, from Jane Foreman. What are your thoughts on how you will integrate the qual and quant findings when in the research process, and how do you go about figuring that out? So I would love to have Jane's guidance on this. As I mentioned, I think there are some places where it'll be very clear for us to do the integration in terms of merging, and that will be the description of the quantitative uptake of the 5 evidence-based strategies. And each of those we imagine will be wrapped around or, sort of surrounded by qualitative data. So the uptake of a particular strategy, and then we describe how that happened. So those are kind of, I think we were able to define in advance. So what strategies were done and how were they done is one little bundle. So those we knew up in advance. But I also think we're in a place where we are exploring other opportunities and really pushing ourselves and welcoming input from colleagues about how to think about integration sort of in real time. As we work through this final wave of data collection for the qualitative piece, I expect we'll have about 6,000 pages of narrative, so a massive longitudinal qualitative data set. And what might we do with that in terms of quantitizing? That's not anything that our team does, but we're excited and always open to new collaboration. So how do we dig deep and leverage what we can from the qualitative data? Maybe that'll give us another way to be thinking about integration. Let's see. Thank you. When you interviewed the hospitals with best practices, to what extent did you rely on respondents' own perceptions of what's working well versus Europe's? Yeah. Great question, right to the nugget of things. And I appreciate this because our respondents, of course, are highly trained, very wise, committed clinicians taking care of patients with heart attacks. And so very articulate respondents who also, have experience and opinions. And so the temptation or risk there is very quickly for them to tip into, I can tell you why we're great. Let me tell you how we do it here. This is why or how. And we very, very quickly would preempt and push them back down into talking about their own experiences. So give me an example of X or Y. Tell me what it's like a day in the cath lab. Describe how you, initiated engagement with the EMS system. So really pushing them back down into the granular description of their experiences, rather than allowing them to go off kind of with opine and conjecture, which well-meaning, but was not what we were there for. So in this instance, it was something we really had to pay very careful attention to, as you're kind of noting. Here's a comment from Jane, which I think is helpful. Interesting that some integration is planned up front and some emerges organically during the study. I think that's true. And for us, we hadn't really thought about it this way. I think it's only because we're now swimming in this qualitative data. So we're learning, as I say, we're kind of learning as we go. Let's see, did you notice any difference in perceptions of people from different cultural backgrounds about the same issue? So Christine, no, we haven't done any kind of deliberate analysis to look at the role of sort of cultural background or even disciplinary expertise yet, say, their views around physician, nurse, dyads, and partnerships. We haven't done that work, but I think that could be interesting, interesting sub-analysis. This is one piece where we are sort of paying attention as we go forward in the qualitative data in terms of opportunities for sub-analysis. So maybe that would be one we could look at. Let's see, Marisa. What are your criteria to stop your sampling process in order to make sure you've achieved saturation as qualitative research? Thank you. So as I mentioned, the criteria in terms of the hospital as the sort of unit of analysis are set. So we're in these 10 hospitals and we're not doing an iterative development of the sample, with new hospitals. So it's that sort of defined in advance. Within those hospitals, we're looking, as I mentioned, each time, so we're doing analysis on each wave of data, the overall data set, and then within each hospital. And so as we uncover new questions, either across the data set or within a particular hospital, we're mindful of that the next time we go out to do the data collection. And so we have the, I don't know, good fortune in this design to be able to go back out 3 times. And we can interview new people if we need to, if we feel like an idea is not saturated, you know, and we're seeing people multiple times in order to kind of keep digging with them. So that's the way we're thinking about saturation in this work. Thank you. Thanks, Leslie. I can look forward to that sub-analysis. Yes, we'll get there, I think. One thing about it, we really do have a fantastic team with the multidisciplinary lenses, I think, so critical. None of us can ever do this alone or from a single lens, no doubt. And so people on the team are really, I think, you know, helping us think about opportunities for various ways of looking at the data set. So. I think maybe there's one more question coming in or comment. No, maybe not.
Okay, well, if that comes in, then we'll be able to read that one. Thank you very much, Leslie. That was great. I've just got a few announcements here from the Mixed Methods International Research Association. They're the group that's helping us put on this webinar series. Just want everyone to know about the upcoming International Mixed Methods Research Conference in Durham, UK, August 3rd to 6th. Abstract submissions close on March 31st, and they have 15 post-conference workshops being offered and accommodations at Collingwood College. More details are available on the MMIRA website. Also, student travel awards are available to support attendance at the conference. The date for application has been extended to March 15th. So you have about a week for student travel awards. Info again can be found on the MMIRA website. As well, IIQM, we have our Qualitative Methods Conference coming up in Glasgow, May 1st to 5th. First 2 days will be pre-conference workshops followed by the conference. And we have the Thinking Qualitatively workshop series taking place June 20th to 24th here in Edmonton. Abstract submission for posters is now open until March 15th. So again, you have 1 week. And it doesn't look like we have any more questions. So Leslie, do you have a word or something you'd like to take us out on? Final thoughts?
No, just a big thank you for people's time and patience and attention, and really an invitation to send along any advice, any comments and questions. I'm really happy to be available. I always learn from others, and so I look forward to those opportunities. That was one reason when Mandy asked if I do this, I said, yes, I'd love to be connected with people who are thinking about the same thing and who maybe have some answers for us. So just, a gracious thank you to everybody.
Perfect. Okay, we'll end it there. The next webinar for the Mixed Methods series is April 12th at 1 p.m. and that will be Jenny Plogue, and her topic is Spread and Scaling Up Research. So hopefully we'll see you all there.